Next, we will have Dr. MIHIR MISHRA talking to us on the
Good morning, everybody. So my study is on outcome of wrapped and unwrapped PMMA implant in an ophthalmic socket. Enucleation and evisceration are the most commonly performed destructive surgeries, and an orbital implant function is to replace the lost orbital volume, maintain the structure of the orbit, and impart motility to the overlying ocular prosthesis. The PMMA is the most commonly used non-integrated, non-porous solid implant, and no other Indian study which has reviewed the outcome of PMMA implant following evisceration and enucleation in the single study. So aim was to study the clinical outcomes of PMMA implant in patients following evisceration and enucleation at a tertiary eye care center in central India. Primary objective was to evaluate the implant retention and implant migration, and the secondary objective was to see the implant movement and the implant related complication like implant exposure, extrusion, conjunctival dehiscence, and the sulcus deformity. So study area was Oculoplastic Services, MGMI Institute, Raipur, Chhattisgarh. All patients with age groups attended the outpatient department, and indication according to the enucleation evisceration will include prospective interventional case series with 9 months period. The inclusion criteria had all the indications for the evisceration enucleation, and exclusion criteria were mostly patients with contracted socket and patients with irradiation or any other congenital anophthalmia. So methodology included the demographic details and the detailed history, comprehensive anterior and posterior segment examination, and oculoplastic examinations. Relevant post-operative and pre-operative radiological investigations were done. Surgical techniques and type of surgery, rehabilitation, and follow-ups were done. So methodology was B-scan ultrasound was taken for the axial length of the normal eye. Donor sclered wrapped scleral thickness was taken as approximately 1.5 millimeter for this donor sclera. Implant diameter was done by axial length minus 5.5 millimeter, including the prosthesis. And the final decision of the size of the orbital implant to be used was based on the clinical and intraoperative findings of the surgeon and the patient's orbital and ocular anatomy. The patient's follow-up was in first, fourth, and 6th weeks post-operatively, and 6th post-operatively, we gave this custom process along with complication which were there noted in that. So this is the surgical procedure which was done for the evisceration with the implant inside the skull pocket, and this is for the enucleation. We have a scleral wrap implant which is placed inside, and it is attached to the four metal muscles to the four quadrants, and the conjunctiva is closed. And this is the post-op photographs where we see the implant is in the central position, and there is good motility along with the cosmesis which is seen after the CMP. So mean age was around 41 years and duration was around 119 weeks. The mean axial length was around 22. The size of the implant was around 16 millimeter, and the horizontal and vertical excision was about 7 and 8 millimeter. Mean motility index was around 4 millimeter. So diagnosis most common was the perforated corneal ulcer, then comes the phthisis bulbi and staphyloma. So coming to the presentations, we had more of acquired conditions, and major complications were maximum 2-3 patients, and minor complication was in just 3 patients. Orbital volume replacement was there in case of 78%, and orbital implant retained was in case of 98%. So these are the good results we got as compared to the other studies. So concluding, PMMA orbital implant in anatomic socket provides adequate volume replacement and good anatomical and functional outcome in case relation to the implant prosthesis movement with minimal complications. Thank you.
Thank you, sir. It was very informative and a nice presentation. I'd like to know how do you manage patients where this implant extrusion occurs, sir?
Yes. So whenever there is extrusion, we have to see like how much it is there, the dehiscence part of the conjunctiva or the sclera in case of evisceration. And in those cases, we try to put an extra sclera, donor sclera in that,
Okay.
if at all it is not necrosed. So any necrosis of the sclera, we have to excise it,
Okay.
then put the flap again, and then we can cover it again.
Okay.
Or if at all we feel that the implant is oversized, sometimes we put 20, 22, and then we have to do the implant exchange,
Okay.
and then we can put a smaller implant. Thank you.
Thank you very much.